Ladies and gentlemen, my name is Tom Farden. I'm Chair of Grand Rounds this week. Thank you very much for coming. A packed auditorium I see out there, which I think is a reflection of how much esteem our speaker is held in. And hopefully you received my email, which gave an unapologetically long introduction about Professor McMurdo's achievements over her long and varied career. She tells me that she is retiring in 2 weeks. It's not just a rumour. And she intends to spend her time being the chair of the BMJ Ethics Committee, which seems like a very large job to take on, but also may indulge in a spot of golf, some travelling, and a bit of well-earned rest. But before we hear her give her final presentation to us, a few parish notices. Staff and students are invited to join the Human Clinical Embryology team for a talk by Lord Naren Patel. The talk will be on regulation of fertility. It takes place on the 5th of November at 4:30 here in the Gannocki Lecture Theatre, giving you plenty of time to get out for the firework displays across the city. A switchboard of molecules that play a vital role in protecting the brain against Parkinson's disease have been uncovered by a research team led by the University of Dundee. Merital Murkett, who spoke here at Grand Rounds just a few weeks ago, in collaboration with Dr. Matthias Trost, analysed tens of thousands of signals to discover a family of proteins called RABs. The discovery opens up new avenues for future research that includes studying whether altered levels of the RABs are associated in the development of Parkinson's, and also suggests it may be possible to treat Parkinson's by developing drugs that directly target RABs. This smiling chap is Ghulam Nabi, and he and his colleagues of the School of Medicine here in Dundee have analysed outcomes for over 300 patients who had undergone radiation therapy for prostate cancer and found that a group of patients who were already taking blood pressure tablets, such as captopril, showed a lower risk of complications arising from treatment in comparison to patients who are not on the same medication, leading them to investigate further ACE inhibitors, in particular in the treatment of prostate cancer. And a group of researchers, including Dr. Sarah Brown and Professor Erwin McLean from the university, have discovered 10 new genetic variants that help determine whether people will develop eczema. In the largest genetic study of eczema in the world to date, this group has combined data on 370,000 participants involved in 40 research studies worldwide. They found 10 new variants, bringing the total number of variants to be related to eczema to 31. This suggests that studying these diseases together in the future could give important insights into the mechanisms of the disease and potentially identify new treatments. A very common disease, which here in Dundee we're making breakthroughs in. I wasn't here at Grand Round last week. I was off enjoying my hoverboard and my self-tying trainers, but this talk was very well received by our iPad feedback system. When you do leave today, even if you have to leave halfway through for a clinical commitment, please vote on the iPads, which are just in front of Dr. Wake there as she sneaks in late. Those iPads, there's two of them. Please vote. It's a simple button. Are you ecstatically happy? And please vote for Professor McMurdo's talk. And that leads me straight on, without further ado, to Marion's talk. Marion has always come to Grand Round, always has a question, so I'm not entirely sure who I'm going to hand this microphone to, unless she asks a question of herself. But I'd like to thank her for her staunch support of Grand Rounds over the last couple of years, and I very much look forward to hearing her talk about multimorbidity and the guideline menace. A round of applause, absolutely. Absolutely.
Thanks very much. Good afternoon, ladies and gentlemen. I don't know if you're aware that the average clinical audience is capable of retaining only 2 messages from any given lecture. Now, I've been observing you very closely as you've been arriving, and I've come to the conclusion that you are an unusually alert, attentive, and quite possibly intelligent audience. So, I'm going to take a massive gamble here today. Please don't let me down, but I'm going to give you 3 messages from this lecture. I'll talk about multimorbidity and show you its strong association with increasing age, but also with social deprivation. I'll tell you that we urgently and radically need to redesign our clinical services to meet the needs of our actual patient population today, who are multimorbid and often old. And lastly, I will liberate you from the shackles of clinical guidelines by highlighting some of their important limitations. So I'll be talking in the context of old age, which immediately raises the question of, well, when is old age? A question I can see is of increasing personal interest to many here today. Now, unfortunately, the definition of old age has become heavily politicised. However, my own perspective on this is that old age is the age at which most of the medical professions start to lose interest in. Now, part of growing up in medicine is about observing the behaviours, the attitudes, and the skills of our senior colleagues, trying to take the best bits from each and then incorporating these into our own clinical life. And I've been fortunate to work with a number of inspirational senior colleagues, and they've been a pretty diverse group. The astute, the meticulous, the innovators, the free spirits, and the mavericks. And the most important lesson they have taught me is the unique balance of having fun whilst taking work seriously. And the people who've inspired me were all enthusiasts. They went the extra mile for the patients, and very often also for their colleagues. And they gave their patients good treatment. Are there doctors who don't give their patients good treatment? A hallmark of bad treatment is non-diagnosis. And here are some examples of non-diagnosis that are applied to people who are old. And all of these terms are bad medicine. Off the legs, not coping, social admission, and most feeble-minded of all, query UTI. Now, social admission I find particularly perplexing because it implies that old people are coming into hospital with the express purpose of seeking out convivial company, stimulating conversation, and perhaps a few quiet drinks in relaxing surroundings. Now, I don't know what your social life is like, but if I were planning a good night out, the medical admissions unit, with the greatest respect, Aaron, would not be on my list of destinations. And query UTI. Oh my goodness. This is the offering of the intellectually derelict, of the diagnostically constipated. No, you do not dipstick the urine of somebody with no urinary symptoms. So the use of all of these terms is inappropriate, unprofessional, and unhelpful. So thank heavens, I hear you say, thank heavens for the wonderful, magnificent doctors who specialise in the medicine of later life. Because we enjoy whole people medicine. We like thinking about the big picture. We're comfortable dealing with uncertainty and balancing probabilities. We're optimistic about our older patients, although that's tempered with reality. But you know, underneath our smiling, carefree, and happy-go-lucky exteriors, we are quietly baffled. We are baffled by the fact that our job is both rewarding and enjoyable, is so counterintuitive to the general public, and indeed to many colleagues in other specialties. But you know, despite our bafflement, even in our darkest hours, we are consoled by the knowledge that, boy, the NHS needs us, not least because of multi-morbidity, which is the presence of 2 or more chronic conditions. The single biggest challenge facing healthcare systems around the world is how to manage the rising prevalence of chronic disease. It really isn't just that people are living longer. It's that people are living with many more diseases and with much more disability. That is the challenge. And at present, only 2 groups of clinicians have the skills to look after people who are multimorbid. Our heroic and undervalued colleagues in primary care, and those of us who specialise in the medicine of later life. So let me show you 2 bits of data on multimorbidity. Data from a Lancet paper published by a Dundee group led by Bruce Guthrie, and the lead author in this paper was Karen Barnett, my former PhD student. So Karen analysed more than 2 million electronic healthcare records from primary care in Scotland. That's more than a third of the Scottish population. And she looked at 40 chronic conditions. So this graph plots age against proportion of the population with multimorbidity. And I hope you are not surprised to see a strong relationship between advanced age and lots of multimorbidity. But this is also plotted by social deprivation. In social deprivation, deciles, or students, we can think of that as tenths. So the red line represents people living in the most deprived tenth, and the black line, people living in the most affluent tenth. So look at this. 26.8% of people aged 45 to 49 living in the most deprived areas have multimorbidity. These are not old people. These are middle-aged people with lots of multimorbidity. And that's a level of multimorbidity which does not occur in those living in the leafy suburbs of Barn Hill for another 15 years. So social deprivation, very strongly associated with multimorbidity. So one more bit of data. And all we need to look at is this very top row here. This is from the same data set, and it looks at which diseases coexist. So of people with coronary heart disease, 52% also have hypertension. 14% also have heart failure. 13% also have stroke, 11 AF, 22% also have diabetes, 13% have COPD, 24% of people with coronary heart disease have chronic pain. 17% have depression, 3% have dementia. So for people aged 65 and over with coronary heart disease have a mean of 4.4 chronic conditions. They're multimorbid. But look, people under 65 with coronary heart disease have a mean of 3.4 chronic conditions. They're multimorbid. In fact, only 8.8% of people with coronary heart disease have only coronary heart disease and no other conditions. So this tells us that if you have a chronic condition, you're likely to have more than one. And it tells us that diseases do not exist in isolation from one another, and diseases do not exist in silos. Speaking of which, how well do our clinical services cater for the reality of multi-morbidity? Well, our services cater very, very badly indeed. Because all our clinical services have been designed to manage individual diseases. But most people using healthcare services don't have individual diseases. They have several diseases. So you need to see a cardiologist about your heart failure. And then you need to see a respiratory physician about your COPD. And then you need to see a hematologist about your anemia. And then, you've got arthritis, so you need to see a rheumatologist. And each of these wonderful specialists, very understandably, focuses only on their own particular disease of interest. But where's the overview? Where's the coordination of care? Where's the integration of care? And this is a tremendously burdensome way of receiving care for patients. So we urgently need to radically redesign our clinical services to meet the actual needs of our patient population today, who are multimorbid and often older. And we need to stop providing our current services, which were designed to meet the needs of the kinds of patients the NHS used to see about 50 years ago. Ken Rockwood, a brilliant geriatrician in Nova Scotia, put it very well when he said, if we design services for people with one thing wrong, but people with many things wrong turn up, the fault lies not with the users, the fault doesn't lie with the patients, the fault lies with the service. So single organ specialists need to stop blaming patients for presenting in ways which they find inconvenient or perhaps insufficiently exciting. Now, I don't know if you can read this. It says, getting old is fun. And for you and I, time will tell. But if you're multimorbid, getting old isn't much fun, because having multimorbidity is associated with just about every single adverse health-related outcome you care to think of. And as a complete aside, I will tell you that the third-year medical students got hold of this picture, photocopied it, posted it up around the entire medical school area with the title, Professor McMurdo in her chair of ageing and health. No, not amused and still indeed on the trail of the culprits responsible. So what does multimorbidity mean for research? Well, people who are multimorbid and people who are old are consistently underrepresented in research. This is true of international research in cancer, in all of the cardiovascular diseases, and ironically, it's even true of international research into some diseases of old age, like Parkinson's disease. Here's the problem. Many of the patients in this hospital today look a bit like this, don't they? Female, over 80, suffering from multiple chronic conditions. They're multimorbid, being prescribed umpteen different medications, and often with a degree of cognitive impairment. But the people who take part in research studies look much more like this: impressively muscular and vigorous young man, male, middle-aged, single medical problem, single drug treatment, and cognitively perfect. So it really makes very little sense to take the findings from research performed in people like this and apply it to people like this. Yet that, of course, is what we do. Which brings me on to clinical guidelines. And my word, what a lot we've got. Between NICE and SIGN and the colleges and the major societies, they are beavering away night and day, churning out oodles of the stuff. And you know, clinical guidelines are such an appealing idea, introduced to get clinicians away from anecdote-based medicine, to get clinicians away from opinion-based practice. So guidelines are a synthesis of research evidence, intended to guide clinicians' decisions about appropriate and effective care. Now that sounds absolutely super, doesn't it? So presumably, guidelines are very useful to us in our day-to-day clinical life. Well, this study looked at a single medical take of 18 patients. Now, I know you all want to go and work in that hospital that only admits 18 patients, but let's just put that to one side. So these 18 patients had a total of 44 diagnoses. So to consult the guidelines from NICE and the colleges on these 44 diagnoses would require reading more than 3,600 pages of text, an estimated 122 hours of reading time. This doesn't sound terribly practical, does it? And there's worse to come. Cardiology is arguably the best researched, most evidence-based specialty of medicine. Well, a review of the guideline recommendations from the American Heart Association found that more than half of its recommendations were based on opinion. Not randomized trials, based on opinion. The very thing guidelines were introduced to get us away from. And there's another problem with guidelines. It's not unreasonable, is it, to expect guidelines on similar conditions to come up with, well, similar recommendations. Oh dear, that was not the case in the recommendations which went out to dentists about antibiotic prophylaxis of endocarditis. It was not the case in a review of the 10 international guidelines on pharyngitis, half of which made diametrically opposite recommendations from the other half. Diametrically opposite. And you really have to stop and ask yourself, is the world a better place for having 10 international guidelines on how to manage a sore throat? And there's another massive problem. There is a working assumption that the best way to manage somebody who has more than one condition is to lump together all the treatments for all the conditions and give them. So how well does that work out in practice? Well, this was a paper written by Lloyd Hughes, an academic F2 doctor, and Lloyd wrote this paper with Bruce and myself when Lloyd was still a student. And Lloyd said, right, let's take a hypothetical 80-year-old lady. And let's say she's got diabetes, she's had an MI, she's got arthritis, she's got COPD, and she's got depression. A not unreasonable combination of conditions. And let's apply the NICE guidelines for each of her 5 conditions and see what we get. Well, what we get from NICE for this 80-year-old lady is a recommendation to prescribe at least 11 medicines, with an option on up to 21. NICE recommendations would suggest for this lady 9 lifestyle alterations. I didn't know there were 9 lifestyle alterations. And just what our exhausted and undervalued colleagues in primary care need to hear, NICE recommendations suggest this lady needs up to 40 additional appointments with her general practitioner. So this is guideline-based practice. It's not safe practice, it's not good practice, but this is guideline-based practice. So I want to do something rather different now, because I know that today in particular I'm amongst friends and colleagues. So I'm going to do something I very rarely do. I'm going to talk about myself and about my health. And I'm going to tell you that I suffer from a particular health condition. I suffer from GFS, guideline fatigue syndrome. And like most sufferers, I developed this condition, this affliction, in midlife. This is a relapsing and remitting condition. And the relapses are provoked by the appearance on my desk or in my email inbox of a new clinical guideline. And when this happens, my famed tranquil equanimity deserts me, and I become uncharacteristically irritable. I'm seen to clutch my forehead and to sigh heavily, and I feel overwhelmed by pointless futility and hopelessness. And incidentally, these are the major diagnostic criteria. So, can anything be done to improve clinical guidelines? Well, the major limitation of clinical guidelines is that they are written for individual conditions, when most patients using healthcare services have multiple conditions. Let's keep working to involve more people who are multimorbid and more people who are old in our research studies. Because in the fullness of time, that research evidence should percolate through into clinical guidelines. And some of us spend quite a bit of our time discontinuing chronic drug treatments. Wouldn't it be nice to have guidelines on that? And how long do you need to be on a bisphosphonate for anyway? Is it 20 years or 40 years? But here's the bottom line. Clinical decision making, the thing that you and I do every day, requires clinical judgment. It requires consideration of the individual patient in front of us, of their particular set of preferences, circumstances, and goals. Medicine is an art, and guidelines are not a recipe book for thought-free clinical care. So let me summarise what I've said. I've talked about multimorbidity, the presence of 2 or more chronic diseases, and shown you its strong association with increasing age, but also with social deprivation. I've told you that we urgently and radically need to redesign our clinical services to meet the needs of our actual patient population today, who are multimorbid and often older. And lastly, I hope I have infected you, if not with guideline fatigue syndrome, at least with a degree of healthy scepticism and a better knowledge of the important limitations of clinical guidelines. Thank you very much.
Thank you very much. So, will you take questions?
Certainly.
Would you like to ask the first question?
Yes. What do we have for lunch? Oh, no.
Right, so it is open for questions. I'm afraid, whilst you're all thinking about it, I'm afraid to tell you that there are now 12 lifestyle alterations because of bacon and sausage. So you're probably jumping out at the right time. Any questions or comments? I think we in the rest of the medical floor really do recognise the ageing population of patients we look after and the multimorbidity. You talked about models and how it could change. But one thing that we've bandied around in the chest department is we'd really like to have a care of the elderly or specialist attached to our ward. What do you think about that? Could we have one of you to come along and help us out with this multimorbidity? As long as it's not miles, it's...
Look after most of your patients with pneumonia already, Tom.
Don't get me started, Miles.
Yeah, so that's a very sweet question, Tom. You would like your own personal geriatrician.
Very much.
Well, I'm sure that can be readily arranged. What we need to do is to sack most of the current clinicians employed in Ninewells Hospital and replace them with people who have the skills to look after people with multimorbidity. So anytime you want your personal physician, just let us know who you'd like to sacrifice and we will fill the slots.
And we can't sacrifice Miles.
That could be arranged. See me later.
Anybody else have any questions? I was in... Professor Marshall.
Whilst I can. Marion, thank you very much for a typically clear and concise talk. I guess I was thinking broadly about a different world where we all had enormous amounts of money to give away. And I was wondering if you would maybe think about what you would do if you were given both £1 million for research. What would be the research question that you would tackle with that relatively tractable amount of money? And then secondly, if you had £1 million to do something that was not research, but would make the start of a change, what would that be?
Well, thank you. I feel like I'm sort of being interviewed for a sort of fellowship appointment that I'm probably not going to be appointed to. £1 million for research. Well, I would give it to Ageing and Health in Dundee, and we would do a randomised trial, a clinical trial, and we would, in our characteristic fashion, involve in that trial people who are very old, people who are frail, and people who are multimorbid, and we would answer an important clinical research question in that grouping. Am I doing well? If I were given £1 million not to do a trial, well, that would be a bit of a bargain, wouldn't it? If I were to do something else that would make a difference, I think that it's a bit social. Sorry if this is a bit woolly and qualitative, but it's a sad thing as we get older that so many older people are isolated and lonely. And actually, there's hard research evidence that being socially isolated is really desperately bad for your health. It's not just miserable, it's not just sad, it doesn't just get you down, it actually is associated with mortality. So I would use Sarah's generous offer, and I'm just sign the cheque any time, and I would use Sarah's £1 million to look at a way of systematically, in Dundee, trying to tackle social isolation for older people in a way that is acceptable to older people and is not done in a way that's patronising, which I think is easy to do, because there are lots of older people who have time on their hands and are enthusiastic and might enjoy the kind of role of being somebody who minimises social isolation. I mean, Age Scotland, a marvellous charity, are already doing some work on this, and I think that's where I would invest my £1 million, Sarah. Thank you.
You got the job.
Oh.
Thank you very much. That was a wonderful lecture. Thank you. This is just a comment, so there's no difficult question at the end, unlike Sarah's question. But SIGN have actually been listening to you because I'm chairing the SIGN guidelines in heart failure, the new ones. And one of the things we were told to do was as much as possible to address multimorbidity. And so we actually did seek and look for evidence in multimorbidity in heart failure. And actually the only two multimorbid conditions we could find any decent evidence for were anemia and depression. But there's not much evidence in any other coincidental disease. And so to some extent the guidelines have to follow the evidence. And so guidelines can only recommend where there's evidence, and so in a sense you're quite right. The problem is kind of before the guideline bit where people should be doing research into multi-morbid situations. But I did chair the SIGN guidelines last time round in 8 years ago, and there was absolutely nothing on any multi-morbid condition. So the fact that we can now come up with evidence on anemia and depression is at least a start. So, SIGN have been listening to you.
Well, how very rewarding. And I'm not at all surprised Professor Struthers, who is deep in his soul, is a geriatrician. And I'm not at all surprised to know that your instincts have drawn you and improved SIGN's thinking about guidelines. So well done. There's a question for Anne-Marie, was it?
Do you think there's a little bit of geriatrician hidden amongst all of us? It just needs to be released. That was a negative. That was a negative. No. I wish there were, but I actually don't think there is.
Thanks, Marion. That was a wonderful talk. I really enjoyed that. This is a comment again, and not really, I'll put you on the spot question. But, you talked about redesigning our healthcare services.
Yeah.
But you also touched on loneliness in the elderly. Mm. And so I feel, from a cardiologist's perspective and a social observer, that I think we've really marginalised elderly people, not just in the medical services, but within society. They have so much to contribute from experiences, stories, that we really need to bring them back into society, into our families. They have such a role to contribute from a different perspective, and making that link between the very elderly and the very young. There's so much potential there.
Yeah. Thanks, Anne-Marie. That's a lovely comment. And some countries are trying very hard to make these kind of connections. In the Netherlands, in some of their care homes, a number of places are given over to undergraduates, to students, people at colleges and universities. And part of the deal is they get really cheap, nice digs and, nice food, but part of the time they are with older people. And this apparently works really well for the students because they've got all these instant grannies and granddads giving them advice or not giving them advice. And it works. The older people, most of them, seem to quite like it. So there are links to be made, and it is quite breathtaking that older people are still marginalised in society. When a fifth of our population are older people, it is quite extraordinary that still is the case. We just need to keep chipping away at it.
Any more questions, comments? Oh, yes.
First of all, thanks very much for that great talk. I'm just a humble medical student, and I'm conscious this is following a sort of old person giving young advice, so that's not intended at all. This is just a question. We're just starting to sort of hop onto the conveyor belt that is the medical profession. How do you think my job is going to be? How do you think my job's going to be different to that of previous years in terms of structure and skills, particularly with a view to service redesign and things like that?
Goodness, what an incredibly difficult question. Sorry. No, well done. Are you a current fourth-year student doing your ageing and health blog?
No.
Exceptional, well done. Well done, you've scored 10% and you haven't done your block yet, so excellent. How will your job change? Well, you are very likely to spend a lot of your professional life providing medical care for people who are older. Lifespan is increasing and continuing to increase. There's absolutely no suggestion that's coming to a halt. So I would think when you come to retire, it will be very common for you to have people in your ward who are 120. We really need to change the way we think about old age. We're going to have 5-generation families. It's going to be, it's radical. Is that a young person's word? Or wicked, is that a good, or sick? But it will be jolly, exciting and interesting to be following your career path. So please learn as much as you can about the good, appropriate clinical care of older people.
A radical question from a young geriatrician.
Thanks again, Professor McMurdo, for a really entertaining talk as always, and we'll really miss the talks you've been given. Just a quick question. Obviously, you've highlighted about the importance of multimorbidity, and particularly in older people. And obviously, conditions such as coronary heart disease, COPD, they all flag up other morbidities or multimorbidity. Now, obviously, in an ideal world, having different professions involved, such as the cardiologists, the respiratory physicians, there, as you quite rightly pointed out, there's no one overseeing all the medications that these patients have been put on. Obviously, in an ideal world, it would be nice to have a geriatrician involved, but you quite rightly pointed out about the importance of primary care. Do you think we're underutilising primary care and sort of overseeing maybe the sort of many polypharmacy reviews and their expertise that maybe could bridge the gap, that we're maybe missing a trick?
Yeah, thanks very much, Louise. I don't know, are there any primary care people here? Well done, you. I think you're already doing this, am I right?
We are starting to work with the polypharmacy reviews.
Yeah.
It has been brought up in various areas of both the GP contract and the work that we want to be doing.
Yeah.
But it's a massive job to do, to work with. And because of, the number of hospital admissions, the number of people being involved, and the advice we get, it becomes very difficult, as you say, to stop medication that has been started on good or appropriate guideline evidence. So stopping medication is difficult. And even with, I work in Perth, the care of the elderly department there, we work with John Harper doing some polypharmacy reviews in care homes. And even there, we can only get a limited amount of medication stopped. But we do our best. We try and work hard.
So well done, the GPs in Perth. I think it depends. It's a big question, Louise. It depends a bit on the kind of pattern of multimorbidity, and people are trying to come up with patterns of multimorbidity. So if you've got heart failure and angina and peripheral vascular disease, pretty much regardless of age, you should be seeing a cardiologist. But most people with multimorbidity don't have that sort of tight cluster of cardio kind of conditions. Most people have a broader spectrum of conditions. And at the moment, the people who have the skills to look after such a broad spectrum of multimorbidity are our wonderful colleagues in primary care and ourselves. So do we really need to radically change the way we train our clinical staff across HPs, nursing, medical, the whole jing bang, that they just have to do a core of good quality experience in the medicine of later life?
Oh, there's more questions.
Steve, we need to record you for prosperity, mate. Yeah.
Thanks again, Prof. McMurdo. How do we influence the pharmaceutical industry to encourage to recruit more older patients into their clinical trials and to have less restrictive comorbidities when they're testing for new drugs?
Yeah, thank you, Steve. I mean, that's a tricky one, isn't it? Because if you think about it from the point of view of the pharmaceutical industry, you've got a newish drug. It's cost them squillions of pounds to develop it so far. They're now at the clinical phase of testing. Their preference is to do a trial in a group of patients who are least likely to have other things happen to them. So they don't really want to do a study in people who are very old, because if you're very old, medical conditions occur. You might have a fall, you might have an MI, you might have a stroke. This is what happens as we get older. So that's the motivation for the pharmaceutical industry to say, no, we're going to study these tennis-playing young men. Various organisations are lobbying the pharmaceutical industry, including the European Medicines Agency, to say, we understand that, but is it really right that a drug can be licensed based on being studied in tennis-playing young men and then prescribed to somebody who's 94 with 10 comorbidities and 15 different medications? It just doesn't make sense. But at the moment, there's no commercial incentive for pharmaceutical companies to actually do that. Here's a question from Ron.
It'll probably be very technical and intellectual, haematologist.
Just a comment on the last point, that there maybe is a commercial benefit. So some of the biggest trials recently have been the new oral anticoagulants, and the benefit that they saw in those drugs when they've subsequently done the subgroup analysis, they'd have seen no benefit at all if they hadn't included the old frail patients, because those patients benefited by far the most. They had big benefits over standard therapy with warfarin, and if they didn't include those patients, they wouldn't have seen any advantage of those drugs. So they'll maybe then look at that and going forward and realise that's not the only group of drugs, but many treatments. You think the risks are with the elderly, but you actually get a lot more benefits there because they've got higher disease burden. Yes. So that's one incentive to get a lot more of these patients into trials.
Yeah, good, very good point, Ron. Thank you very much.
The same is true of macrolides in bronchiectasis. The people over 85 get 5 times the benefit of people under 65, and actually the older you are, the bigger the benefit. So you really ought to be giving it to the 95-year-olds, which I think is perhaps in Contrast to what I spend most of my time doing on ward rounds, which is stopping drugs in 95-year-olds that improve their 10-year mortality by 3%, which most 95-year-olds don't care about.
Hello. Do you think we should focus on having a specialist geriatrician working in every department, cardiology, gastroenterology, respiratory, whatever, or should all specialists spend time as registrars, maybe a year, working in geriatric medicine?
Thanks for that.
Yes. Yeah, starting now. Well, you probably need a bit of both. My response to Tom earlier is, if you really want to build up the expertise of senior clinicians who understand the medicine of later life, then appoint more of them and appoint fewer of the single organ specialists. We need the single organ specialists. We love them. But actually, their target population is becoming less and less. So we need them, but we probably don't need as many as we've got now. And this is the bullet which the NHS has never had the gumption to bite on. So I would vote for both. And there's been a kind of token chit-chat for years on and off about, oh, yes, all people who train in medicine will do some work in medicine for later life, but it's tokenistic at the moment, Ian. Maybe you can drive the revolution. The revolution is coming, and Ian Logan is pushing it.
You'll have to find out whoever it is who's the TPD for general medicine.
So you mentioned that it's not only medicine of later life that has to deal with multiple morbidities, it's also people who have like social deprivation, and they're actually a lot younger. So instead, would you maybe advocate a system that's becoming more popular, I think, in Germany and the US, of internalists? So internalists are doctors who are generalists in the hospital. That's what they specialize in general medicine. And they have an umbrella in that they oversee patient care and all the pharmacology and things like that. And it is becoming more popular in the US. I mean, they have a lot more money. But would you maybe say that we need more of a shift towards that in hospital medicine?
Thank you. I don't really know very much at all about internists, did you call them that, in the US? I don't really know that system at all. But, I'm not that old, and there used to be a lot of general physicians, and now everybody, for very understandable reasons, and it's the way healthcare policy has driven things, many people who were more generalist individuals are now driven into more silo-bound, more technical, high-tech, interventionist specialties. And that's great for the people who get that high-tech interventionist care, but there are swathes of people that we don't actually have the skills to care for. And quite how we best do that, I don't know about the American model.
Right. That was just a couple of questions. I came to this hospital in 2003, and all I knew about Professor McMurdo was that she was the slightly scary lady who was in the department next door to mine. But I've come to know over the last 12 years that of the inspirational subgroups that she described, I think astute, you could certainly apply. Meticulous, certainly apply. I think eccentric, perhaps she left to others. But maverick, maybe. It's a rare privilege to work with someone who is an internationally respected leader in their field, but I think that's entirely appropriate to say of Professor McMurdo. I will personally miss her contributions to Grand Round. I know that her colleagues and her trainees and those who've done their PhDs with her will miss her greatly. I'm very grateful on her behalf for you turning up today to have such a large audience. Thank you for your comments and questions, and it's with a sad heart in some ways, but also with pleasure that I announce that she's leaving in 2 weeks to go and be the ethics chair, but I suspect we'll see her again. Thank you very much, Marion McMurdo.